Thank you, Trev, and thank you, Martin, for inviting me. It's a really superb week. It's been so enjoyable so far. But talking on day 3 is a real challenge. Every 2 hours, I have to update my talk to kind of take into account and point out the synergies with the really superb sessions we've had so far. This is the original title. I varied it slightly, but I want to first just say, what sort of person am I? I'm looking around and talking to you over the posters. There's a lot of diversity in the backgrounds. So I thought I'd just spend 2 minutes saying, well, what sort of a scientist would I be? I began life in my teens. I was assessed by quantum physics. And actually, after I left school, I worked for the Atomic Energy Authority for a year. And that was really sort of the academic intellectual drive in my teens. But then 2 books came along, which they're a bit old-fashioned now, but I'd highly recommend them, from Douglas Hofstadter. These are beautiful books introducing aspects of philosophical, neuroscience, art, music, woven together into a truly extraordinary story. And I would highly recommend them. And they got me more interested in areas of artificial intelligence, what might call now some aspects of neuroscience. But these areas were very difficult to reconcile with my sort of inner vision and aspiration to be a doctor. Okay? And it was difficult to bring these threads together until I met this man, who's Trevor, many years ago as an undergraduate at Cambridge, and who opened my eyes to what was then experimental psychology and is now really probably reframed in cognitive neuroscience or translational neuroscience. Scanners existed, but they were pretty primitive, but there was a tremendous excitement about what scanners could offer, particularly to bring things beyond just animal or rodent and marmoset models into understanding human neuroscience and human cognition. So a short, there he is now, little change. So there we are. A short hop's given a jump through Oxford and UCL, where I finished my medical training and neurology training, working with Dick Passingham. Dick was very influential, although by the time I met him, he was very much excited by the potential and applications of imaging. His background was actually in monkey lesions, monkey physiology, and then to some extent pharmacology. So that really taught me that imaging has to be set in the broader context of neuroscience and animal work, and be inspired by animal work and challenged by animal work, working backwards and forwards. Richard Verkovac, also a remarkable man, a great inspiration in terms of clinical neuroscience, and with Martin Rosser showing me really how to engage with that with aspects of disorders of cognition. I later had the good fortune to work with Gita, so it's very nice to see her here. So I'm technically a neurologist, but I mostly work with psychiatrists. I work on a lot of psychiatric phenomenology of impulsivity and psychosis. I work closely with psychology. I'd still aspire to be a dilettante psychologist. Pharmacology is really at the core of a lot of the work in combination with imaging. So all wraps up in neuroscience. And I think many of you either have diverse backgrounds along these lines, mixing science, medicine of different branches, animal and human work. And I think it's just a fantastically exciting meeting to see that coming together. Can I have a quick show of hands? Who here would say their main work is on rats or rodents? Yeah, majority. Who works on non-human primates? Who? Not many, oh dear. And who works on people, mostly? Oh, that's better than I thought. Okay, good. We need more primate work. The link between the two. So I'll try and bear that in mind. So I've modified the title. So Noradrenergic and Serotonergic regulation of behaviour, not just response inhibition. You'll see why in a moment. I will talk about some of the cognitive deficits in Parkinson's disease. I'm going to start really the first hour focusing on Parkinson's disease, and then move on to some other illnesses called frontotemporal dementia. I'll point out the complexity of impulsivity and the multiplicity of drivers or contributory factors. I'll show how serotonin and noradrenaline can be used to try and restore function, and how you can then also try and use imaging to predict which people will benefit. Not precision medicine as such, but certainly stratifying. I'll then switch to another aspect of the cognitive syndrome in Parkinson's disease, reversal, learning and attentional shift. We heard much about this in Trevor's opening remarks on Monday and yesterday from Roshan. And then I said, I'll take a short break in the middle for a bit of fun to think about how you do these studies in practice for about 5 or 10 minutes, just what the reality is of doing human psychopharmacology with imaging. I'll then come on to frontotemporal dementia, and if there's time, I want to touch on some modelling perspectives. Perhaps I should premise this by saying that the best model to study Parkinson's disease is Parkinson's disease. Yeah? Dopaminergic manipulations give you very little insight to Parkinson's disease. Yeah? If you want to study Parkinson's disease, study Parkinson's disease. Now, to understand dopamine, study dopamine. Yeah? dopamine psychopharmacology. Don't go away thinking that Parkinson's disease is a useful model of dopamine. It isn't. Okay? It's misleading. It's full of pitfalls. You've got, as we'll see in a moment, dopamine is just one part of the Parkinson story. You've got structural changes. You've got changes in almost every other neurotransmitter. I'll focus largely on serotonin, 70% depleted, typically. Noradrenergic, again, 70-80% depleted. Not as bad as the 90 to 95% depletion of dopamine, but it's a big part of the story. And you've got everything we've heard about orexins and glutamate. They're all dysregulated in Parkinson's to a greater or lesser extent. So if you want to study Parkinson's disease, study Parkinson's disease. But don't think of it as a dopaminergic model and vice versa. And let's see where we go. So with that in mind, a little caveat, let's think about the cognitive syndrome of Parkinson's disease. At one extreme, I'm not going to talk much about this, but we'll sort of get it up front, there's the aspect of dementia, prominent visuospatial deficits, very much as a posterior occipitoparietal deficits, hallucinations that we discussed at the end of Michael Hasselmo's talk yesterday, and this dementia. Clinically, we think of this very much in terms of cholinergic deficit and in posterior cortical systems. It's different from how we make decisions, and Parkinson's patients are bad at making decisions. They misattribute risk and outcomes, okay? And they may fail to gather sufficient evidence on which you could make a good judgment as to what that decision should be, called reflection impulsivity. They're prepared to commit themselves to a decision when they really haven't got the information necessary. And that's different, I think, from a more broader class, a rather messy class of tasks or paradigms called executive function test. It's a widely used term, often abused, but it covers a number of different areas. One is in terms of inhibition, also how we have task sets or rules that govern behaviours in given contexts, so the contextual dependency, and also how we plan ahead over time. And all of these really come under the rubric of executive functions. I'll come back to attentional shifts, picking up on Trevor's distinction from Monday between extradimensional and intradimensional shifts versus reversal learning. We'll see that's going to be quite an important distinction. But I'll start by thinking about aspects of inhibition, the different types of inhibition, how you have to restrain from an action or hold back. We might see this in terms of waiting, okay, and delay intolerance. We heard in some of the earlier talks about premature responses on the 5-choice serial reaction time task, a classic task in rodents and to some extent higher mammals, but not being able to wait. There's also an aspect of restraint which is to simply not go at all when you shouldn't go, so typified by a go, no-go task. Okay? But you haven't actually activated the movement, you have to simply hold back from even initiating it. That turns out to be very different from another form of inhibition of responses, which is cancellation. You initiate a movement and then have to cancel it. Okay? You might, an example in everyday terms, at the traffic lights go green, you initiate a whole series of complex actions, the handbrake, the steering wheel, and the accelerator, off the brake, onto the accelerator, and then somebody walks out, a child walks out, and you have to kind of cancel all those actions midstream, and cancelling responses. You end up not setting off. It's actually very different from not even initiating. So stopping and not going are very different. But all these aspects, deficits in any of those sort of cognitive components could lead to impulsivity and impulsive behaviours. And they matter. So if you keep up with the literature, the Daily Mail's very good. Parkinson's medication turned me to gambling, gay, sex thief. So it doesn't get much better than that, does it? Yeah. The £500,000 it cost the hospital here because they gave a chap some Bertinoro and he turned himself into that. And even when the drug was stopped and he stopped behaving in this way, his marriage was wrecked, his pension was spent, he was humiliated in his neighbourhood. You can't recover from that, okay? Even though you pharmacologically withdraw. And this is not just Parkinson's, you see aspects of these behaviours in a whole range of other neurological disorders. So what is impulsivity? Well, it's multifactorial. It's a complex set of ideas. Risk and reward gambling is one context which is often studied. Not taking notice of high-risk outcomes is another. You might think this is a joke. I've had a patient who more or less did this. They put a chair on top of the dustbin and had a chainsaw for doing something up here, chainsawing high. It happens. It's terrible. Making decisions when you simply should know that you shouldn't yet make a decision. You've not got enough information to make that decision. Another aspect, delay intolerance and disinhibition, simply not being able to not go. And I'm going to focus in the first part of the talk on this aspect, not because it's more important, but actually it's one aspect in which we have very good translational pathways for mice to rodents, marmosets, students, and on into patients. With humans, actually not students. You'll see them mostly are students, which is quite fun. So if we take patients with Parkinson's disease and we throw a whole battery of tests that might use questionnaires about how impulsive they are, they might use some behavioural tasks about how one inhibit prepotent responses, so saccade and manual go and no-go tasks, the stop signal there, gambling, estimation of time and delay tolerance. Patients are pretty bad across the board. Okay? They're bad at all these tasks, more or less. The question is, though, what can we learn behind that? It's not a single entity. They're bad for different reasons. And a lot of our work in the last 10 years, both in the clinic with Roger Barker and with Trevor, and the animal work behind the scenes, is to pin down these multiple drivers or multiple contributors to impulsivity. So let's try and pick our way through them. How might we look at this? Well, we would start with perhaps a simple paradigm, like a stop signal task. In a stop signal task, you would get people to, using buttons, to go left or right, and after you've told them to go to one direction, very soon afterwards, a few hundred milliseconds, you give a stop command, a count command. It can be a beep, it can be a change in colour, it can be various things, but it's a signal to stop, and they have to cancel what they've done. Depending how much advanced notice you need to successfully stop, you could say someone is a good stopper, an efficient stopper, if they can actually successfully stop even very late on in the day. So if that stop signal is given very close to when they would have gone, their normal go reaction time, they're efficient at stopping. Other people have a long stop reaction time, which means they need a lot of advanced notice to successfully stop. Okay, so the stop signal reaction time is a measure of how efficient you are at stopping. And if we look at this task, this is a meta-analysis from Charlotte Rowe, do a meta-analysis of people in an MR scanner performing this task. You get consistent activations both on the medial wall, down the brainstem, we'll come back to where that might be a little later on, and a key area here on the lateral prefrontal cortex, and inferior, particularly on the right. That area is of interest because lesions there cause impulsivity. In fact, the greater the lesion, the more impulsive you tend to be. This is in healthy adults. In people and in rats and marmosets, where it's been looked for, this is subject to quite specific neuromodulations and starting to pick up the neuromodulation theme. If you use atomoxetine, which is a selective noradrenergic reuptake inhibitor to enhance noradrenergic transmission, what you see is you get a reduction in stop signal reaction time. In other words, you get better at stopping on atomoxetine, not with a serotonin reuptake inhibitor, citalopram. Okay? So noradrenergic rather than serotonergic modulation. And I've forgotten momentarily which is rats and which is people, but what is one of each? It's replicated. Now, what was then interesting about the atomoxetine noradrenergic story is if you give atomoxetine to people performing the task in the scanner, this critical area of the right prefrontal cortex is active, but its activity is proportional, when you're successfully stopping, proportional to the drug level. So you give a standard dose, okay, orally, and there's a very marked variation. First question, get a prize. Yes?
I was just wondering, this doesn't really fit with what we just heard from the previous talk.
Yeah.
That early tendency not to be involved in this non-stop contest, non-goal contest, right?
Yes. So remember, you're exactly right, spot on. This is stopping, not going. Yeah, well spotted. That's a very important difference. So actually, in the animal models, atomoxetine has minimal effect on not going. Ironically, well not ironically, serotonin has an effect on not going. So that actually, pharmacologically, there's a dissociation in the animal models. It's not quite so clear in humans, at least in patients, I should say. But don't forget, this is cancellation type inhibition at the moment.
So they already estimated the decision to do something?
Yes. They've initiated it, those representations of motor acts are rising, they're reaching a threshold at which point the movements will be executed, but in those few hundred milliseconds, you've come in with a countermand, and there's then a race, if you like, between a process that's ongoing to make the movement and a stop process that has to kind of get there first to cancel the response. Yeah. In this context, yes. So why am I talking about this in the context of Parkinson's disease? A very simple observation. Patients with Parkinson's disease lack noradrenaline. There's many studies. This is a post-mortem study, and you're 50, 60, 70% depleted. Okay, a very dramatic effect. So it's relatively simple logic to say, can we restore some of the inhibition deficits and impulsivity in patients by enhancing noradrenaline? So I want to keep that as a question. We can turn it to hypothesis a bit later, but that's really the question. Could we restore function? I'm going to take you to another task, a no-go task. So we've switched tasks now. Again, go left, go right, go left, go right. And at this point, you get a stimulus that doesn't initiate action, it tells you even at a time point when you might want to be expecting to go, you have to not go. So you don't initiate the response at all. This also causes activation of that infrafrontal cortex. On crude imaging, it looks like the same area. There are some subtle differences actually in terms of exactly where it is, but it's very similar, right infrafrontal cortex. That in humans and marmosets and rodents is subject to serotonergic modulation. So this is a study undertaken with Gita a few years ago in healthy young adults, mostly students, and the activation here was sensitive to tryptophan depletion. So if you acutely deplete people of tryptophan through a rather disgusting oral drink of amino acids minus tryptophan, you get a transient, quite severe reduction in central serotonin 4 or 5 hours later, and it's fairly aversive, but it can trigger depression if you're vulnerable, for example, but it also has impact on non-affective serotonergic functions like motor control and inhibition. So you can alter the activity of the frontal region by tryptophan depletion. What was then an important aspect of that study was the extent to which that state or transient manipulation of serotonin affected you was proportional to your serotonergic trait. So in the same subjects, we used a PET study to look at the 5-HT2A receptor density or binding potential, and the effect of the drug manipulation or tryptophan manipulation depended on whether you were intrinsically low or high. So we're going to start to see state-trait interactions, and we'll come back to that in terms of this U-shaped model, or state dependency, baseline dependency, I think was Shannon's phrase. It turns out to be extremely important. Rats too, you can deplete rats of forebrain serotonin, and rats cannot learn a no-go task. Even a healthy rat struggles. Even on many, many weeks, they're still at 70-80% on a 50-50 no-go task. They find it difficult. But without serotonin, catastrophically impaired permanently. Now, tryptophan depletion in rats and students, although well, it's not really nice for patients, so we've got to do something better. You can take the opposite view and enhance serotonergic function. Okay? That's using a serotonin reuptake inhibitor like citalopram, and sure enough, you find in an MR experiment you get an enhancement of that right infrafrontal activation under serotonergic modulation. Why am I talking about this at such length? Because of the observation that patients with Parkinson's disease gradually become progressively depleted of serotonin. Various measures. This is the serotonin transporter using PET in living patients. I've taken the prefrontal cortex signal, but actually subcortically as well in other brain regions. There's a progressive decline. What's it, 50% or so, 40-50%? It's a substantial decline. Okay? More so later in the disease. So we're going to come to a second question, which is, could we restore response inhibition by enhancing serotonin in Parkinson's disease? Okay. So this is the basic sort of background. In a state of depleted neurotransmitters, so taking a patient who's in a state of chronic depletion, can we restore neurotransmitter function and thereby restore performance? Targeting either serotonergic systems with citalopram or noradrenergic systems with atomoxetine. Okay. These two drugs are highly selective with respect to the others transporter. They're not, there's some sort of partial effect on dopamine transporter each, and there are some other complex interactions which we'll see playing out in the patient studies later. But they're fairly clean cut with respect to each other, which is why we chose these two compounds. So we undertook a double-blind, placebo-controlled crossover study in Parkinson's disease with patients with mid-stage Parkinson's disease, and we were using fMRI to really assess focal target engagement in the cortex and subcortical systems to really reinforce our predictions from the animal models. We were not looking for clinical outcomes, we're looking for sort of mechanistic insights. This is in older controls, looking at activations when you have to stop. And you get this very strong activation on that inferior frontal gyrus. It actually goes up in a swathe up to the dorsal frontal cortex. Don't be too distracted by the visual and temporal activations. These really reflect that color change and beep that was the countermanding cue. Okay, so these are really the sensory aspect of that stop cue. We interpret this as being the consequential inhibitory drive. Patients are worse than controls, so just to focus down here, they have less activity on stop trial. So that's the area we're going to focus on, that critical inferior frontal gyrus. And let's look at the effect of atomoxetine on the top right-hand side. Well, compared to placebo, atomoxetine increases activation on stop trials in this area, but not in everybody to the same extent. So there's a correlation here that your disease severity The UPDRS is a common measure of disease severity. It goes from 0, which is be in pristine normal health, to 100, to which you'd be in the ground. Most patients, by the time they get to 50, are really in a wheelchair and maybe not coming to clinic very readily. By the time you're 60, 70, you're moribund, you're bedbound, and you don't survive to 100 points. So these are mid-stage, 20, 30, 40 points. They are obviously quite ill patients, but they'd still be walking, falling over a bit, still be walking and talking, although not normally. So here we are. So the atomoxetine, there's a clear effect of the drug, actually also on of citalopram. Increasing activity, not such a marked effect. This is on a stop inhibition, so in a sense from the animal models it's surprising we see any effect at all, but we do, but again it's dependent on disease severity. Okay.
Sorry, what is the timing of this? So when firstly when patients actually receive the drugs, but also is this all sort of when are these activations being recorded?
Oh, yes, good point. So we give the drug orally, we'd wait 2 to 2.5 hours before we start imaging. We know from doing day curves, that's when you reach peak. You reach peak at 2 hours, you stay at peak for about another hour and a half, and it then gradually fades away. So we're at or near peak during the whole imaging session. The imaging session takes about an hour, 20 minutes of which is doing this task, the rest is doing some other sequences in the scanner. And during the 20 minutes of this task, there are trials every probably 3 or 4 seconds. And that's a mixture of the majority are just go trials, and then you have stop and no-go trials intermixed on 30%. And then we're averaging all the activations in relation to those successful stopping trials. Okay. So, yeah.
The graph is showing disease severity versus how much citalopram or atomoxetine changes the...
Yes, so this is a delta activation, change in activation. Yes.
Imaging. Does it also relate to delta behavior?
It does partly. To see the behavior, you need to take some other things into account, which I'll come to. So this at the moment is about, can we increase the activity of this region? Okay. Translating that into behavior is critical, but the short answer is it's not enough to tickle the cortex. Unless that cortex is anatomically and functionally connected with output systems that actually mediate behavior movement, just simply changing that cortical function is not enough to change behavior. But we'll see the evidence for that in a moment. So what we'd say is frontal cortical activation for inhibition is reduced in PD, but in more severe disease, both atomoxetine and citalopram increase the activation. We're going to want to look at connectivity to see how this plays out in a broader brain system. These areas are not acting in isolation. So one observation is in separate patients that Parkinson's disease itself changes brain connectivity, changes structural connectivity. So what we've done here in green is to collapse all the white matter onto a sort of roadmap of classic tracts. Okay? So you're moving all the white matter tracts onto a sort of skeleton, okay, from which has technical reasons, makes it easier to see where changes are occurring in the white matter. And I've overlaid on blue areas where there are changes in the properties of the white matter. So this is using diffusion-weighted imaging, looking at the extent to...
These structural conditions, have you checked the volume changes?
Yeah, so at a group level, volumetric changes are very subtle in PD. You get subtle atrophy. You do get some atrophy. It's certainly grey matter, which is most around the medial cortex. And you get obviously quite marked changes with age. So we've corrected for age in this analysis. You'll see later in the frontotemporal dementia session, in the sort of second half of the talk, you get gross structural changes, volumetric changes. But here we don't. So we're thinking about really the white matter tracts that are connecting out to these lateral frontal areas are abnormal. What we then found, or Zhengyi showed, was that whether you got a response to atomoxetine, so a change in behavior, that stop signal reaction time, okay, so whether your behavior changed in response to the drug was proportional to the structural integrity of this frontostriatal path. Okay. So giving the drug only changed behavior if that infrafrontal gyrus was connected well. Of course, with time, those pathways degenerate in Parkinson's disease, but there's a sweet spot. So these pathways are degenerating, but those with what you might call relatively preserved connectivity are the ones who are able to benefit from the drug behaviorally. there's another aspect of this, which is if we compare the functional and structural connectivity. So this is, it's had to be flipped because left-right I flipped, but this is the same map. This is the right, so the pathway is coming in from right infrafrontal cortex, coming down between the choroid and putamen. It's not clear whether these branches are actually going to connect to choroid and putamen or whether they're going to go past the subthalamic nucleus, and we'll see some modelling of that in a moment. But if we just look at, if we take that infrafrontal gyrus peak of activation and say, which parts of the brain does it correlate or couple with most tightly? Okay? So you can look at correlations between that source region and any other part of the brain. And you can say, where is there abnormal coupling or abnormal correlations in Parkinson's disease? We see one place, which is here. So this is the region of abnormal functional connectivity from infrafrontal gyrus. And if we just align these structural changes that are so critical for the atomoxetine response and the functional abnormality in connectivity, I think there's a remarkable alignment there. So we're starting to see a synthesis of structure, function, and drug responsivity. That's important if we look at these tracks in a bit more detail. So plotted in blue, this is a track from that pre-SMA, that medial frontal area coming down towards the subthalamic nucleus, or coming in laterally from the inferior frontal gyrus, coming down past that region I showed you in terms of atomoxetine, but going past it to subthalamic nucleus. The average integrity, we're using a diffusivity measure here, the integrity of that pathway correlates with behavior. So the stop signal reaction time here, actually here, these people are good responders, have low mean diffusivity, which means they're very well coupled, well-aligned fibers. Okay? If you get disordered fibers or swollen fibers or damaged fibers, you get increase in diffusivity, and those patients have longer short stop signal reaction time. In other words, they're worse at stopping. So the integrity of these tracks is important for behavior. So we're going to ask another question now. How do you stop what you're doing? Yeah? You know what I thought about? How do you stop it? It's all, well, you know, I think it was easy. Just, you know, tell a person, just don't do it. You know? How does that happen, though? And really what's happening in the animals? Well, what do you need? You need several bits of the system to work together. I mean, ultimately, you're going to have to change those outputs from the corticospinal tracts, okay? So stuff has to happen that will change corticospinal, perhaps also cerebrospinal outputs, which is the source of those outputs down through the spine onto the primary motor neurons. There's an important brake on the motor system provided by the subthalamic nucleus, okay? Actually, a brake on the thalamocortical projections. And there's some very nice work, I think particularly Michael Frank, which Roshan alluded to in her talk, but also on Berta Forsen and Antonio Strafella, showing the importance of that subthalamic nucleus. Especially important in Parkinson's disease, this is the most common target for deep brain stimulation. Okay? So you need to, that's part of the system for stopping. We also want to come back to that medial frontal area, the pre-SMA, which is a lot of attention paid to its roles in selecting action, perhaps, but it's also been proposed as a site for inhibiting actions. Sue Hussain and colleagues perhaps suggesting that its activity comes before that lateral prefrontal cortex. Okay? So important for inhibiting and selecting action. But we mustn't forget our friend here, the infrafrontal gyrus. Strong evidence that it's involved in actually the inhibitions. It may not be a source of electrophysiological inhibition, but there's other ways that you can inhibit responses without electrophysiological inhibition. So Adam Aaron and Ross Poldrack just very nice work with Trevor. I think 2003 was the classic paper showing that damage to this area proportionately impairs impulse control. There's sort of alternative view floating around that it merely reflects orienting relative to relevant events, sort of salient events, on which basis you then inhibit. But I think that's losing ground. So these areas really form part of a network. So in the next few slides, I'm going to talk about how we can use imaging modalities to understand the strength of connections and the role of that connectivity in humans. So this is the network. I'm going to sort of move it there. Keep in mind the pre-SMA and infrafrontal gyrus, these prefrontal cortical areas, which may or may not project to subthalamic nucleus and ultimately affecting motor cortical outputs. So here are, that's the network. Okay, now, you could use MRI to use functional imaging using a signal called the Bold signal, which really reflects the fact that when nerve cells are more active, they trigger through a series of processes an increase in blood flow locally, and that reduces the oxyhemoglobin content. Okay? And that's, if you compare oxy to deoxyhemoglobin, you go from paramagnetic to diamagnetic, it changes the MR signal. So by sort of chain of causality, your MR signal can be used to infer metabolic or neuronal activity. But that chain turns out to be quite important. So we want to understand neural interactions, okay, in people. The neural interactions that are consequent to a stop command that enable you to successfully stop. But what we've measured is a functional MR map, okay? And it's not the same thing. What the functional MR map is really looking at hemodynamic changes. Hemodynamic changes in response to neural activity, but it's not the same as neural activity, and there are important differences. So you go from neural activity, which induces a vasodilatory signal, you get a change in flow, you get a change in local volumes, change in the hemoglobin, and these two factors between them change that bold signal, that magnetic signal that the MR is reading. Okay, so you've got this indirect chain. So with the method DCM, with a relatively sort of sparse human image, I won't spend too long on the method, but you can estimate the parameters of neural connectivity at the neuronal, separate from the vascular levels. Okay? And we're going to fit a model of connectivity, maximizing the evidence from the fMRI, but the model and some parameters on this neurovascular coupling in order to parameterize that neural connectivity. Just to reinforce that, so you go from experimental stimulus, induces neural activity, there's this complex coupling which eventually leads to bold response. And the problem is both disease and drugs. Yeah, they might affect your neural activity, that's kind of what we're interested in. Yeah? And what you might measure directly in an animal, neurophysiologically or voltammetry or whatever your method. The problem is these drugs also affect neurovascular coupling. So we need a reliable method that can disentangle that. And so DCM provides this. We establish a neuronal model of that network. We have a hemodynamic model, and you can alter and adjust the parameters building on some empirical priors. There's a very nice series of methods to get sort of optimization across multiple parameters with what's called a generative model. In other words, your brain model and your hemodynamic model make predictions of the data. Okay? And you then say, well, how good are those predictions to the actual data? And you optimize the model to get as close as you can to the actual MR signal. Okay? And it works very well. So the system we're modeling is at the neuronal level. So we're going to come to that. We're going to keep these areas of our model. So bear those in mind. There's many ways these areas could be connected. Okay? Many ways. So when we think about how to stop, we could compare many different models. So we could have a very simple model here, for example, in which the pre-SMA and the infrafrontal gyrus are not connected. Yeah? But they both project down to subthalamic nucleus and then up to M1. So one model. A more complex model here is that they have reciprocal connections between SMA and infrafrontal gyrus. Okay? And there's many ways. And we can then look at where is the effect of stopping happening. This little dashed arrow. Does stopping alter the connectivity between IFG and the subthalamic nucleus? Or, alternatively, an alternate hypothesis, does stopping affect the connectivity from the SMA, pre-SMA, to subthalamic nucleus, alone or in combinations? You build a family of models. And you can also have interactions that work in a slightly different way. So here, what we're saying here in this little figure is a nonlinear model in which the infrafrontal gyrus modulates or gates the impact of pre-SMA on subthalamic nucleus. So you get a subcortical interaction or gating, okay, either positively sort of synergistic effects or a negative interaction. So you can compare all these models. Now, because these are generative models and they're fitted to the data, you can get goodness of fit measures. Okay? We actually look at the model evidence, a measure called estimate of the model evidence, correcting for model complexity. And what we get is essentially estimates of log model evidence. And so for every model has this model evidence estimate. You can think of it in terms of a goodness of fit. Okay? Differences in the model evidence, these represent so difference between two models in their model evidence is equivalent to the log Bayes factor. So you can start to think in terms of Bayesian statistics or Bayesian comparison and say, how confident am I, or what is the evidence that one model is better than another? Okay? And a large difference implies a very high Bayes factor. In other words, the data and the modeling provide strong evidence. So the data tell you that there's strong evidence in favor of one model, not another. And you can compare all models to another, either in their evidences or in terms of their posterior probabilities, which takes into account their relative likelihood. What we see here in healthy young subjects is one model provides a really good fit to the data, clearly better than all others. Okay? So a delta F of 5 is equivalent to base factor of 150, for those that work in that, so very strong evidence. So 87 is clear strong evidence. What that model looks like is this. It says that of all those 21 models we tested, the one that was best able to reproduce the MR data was the one in which the stopping signal was exerted onto infrafrontal gyrus, okay, which is connected reciprocally with the pre-SMA, which is not a surprise. But instead of them both feeding sort of independently in parallel down onto the SDN, there's this synergy. Okay, so and the IFG and the pre-SMA interact positively. Okay. So you can escape from this rather silly debate in the literature, is IFG more important or is the SMA more important, okay, which has been tussling to and fro for a decade. You see, forget that. Both these areas are important and they interact positively in their influence on the subthalamic nucleus, that critical break for ongoing behaviour. If we take, for example, the model estimate of this modulatory effect, okay, which is the effect of the IFG on modulating the pre-SMA to SDN, so how strong that parameter is, this couples with that behaviour. Okay, so it's really nice to get some behavioural validation in this modelling. So people who are impulsive have a low or weak effect of the IFG on that connection. People who are not impulsive have a very short stop-signaling reaction time, have a very strong effect of the IFG. So that again, yes.
I have a question. If you say it's a modulatory input of the connection between SMA and SDN,
Yeah.
do you mean it has an indirect connection, or how do you imagine it from a...
Yep. You're right. So you notice, where's the basal ganglia? Where's the cortical putamen? What about direct and indirect? What we've summed up here is there is a net effect of these cortical areas on the SDN. Now that net effect is mediated by direct, indirect and hyperdirect pathways in a variable combination, but our hypothesis focuses on those cortical regions' effect on that SDN. Okay? Now we know there's a lot of complex machinery between the cortex and the SDN, but what we're seeing here is the net result of all that complex machinery, direct, indirect and hyperdirect pathways. We've chosen not to model it. Okay. Partly we've chosen not to model it because this simple model is sufficient for testing our hypothesis. Okay. So don't complicate your models unless those complications are necessary. Okay. There are some technical issues in terms of getting, in older subjects, getting robust putamen, caudate and GPI signals, particularly iron deposition, you get dropout and distortion. And ultimately, for our hypothesis, you don't need it. If you were specifically interested in the relative contributions of direct and indirect pathway, you'd have to have a different set of models. Yeah? A model that was sufficient to test your hypothesis of those differential direct and indirect pathways. Here we're not concerned with that, so we've looked at the net effect.
So just to go over that again, James, because I think it's a subtle point, is that you've already shown evidence that strength per se is relevant, because clearly the integrity of that frontal straight connection is necessary for the behavioural effect of Parkinson, so that's clear. And of course there's a lot of animal work, both with infusions and physiology, on the role of the straighter.
Yes.
So clearly this SMA to SDN connection, as you say, could either be due to its hyperdirect connection or by the intermediate straight systems. It's just, this is just a summary of those.
Exactly. So we're not saying this is not here. It's that those direct and indirect pathways are implicit in this model. I've not illustrated. I could have sort of put them in, but had arrows that sort of just run straight through. But this is a simpler way of presenting the model. Yes.
Why is longer reaction time considered more impulsive?
It's not a reaction time. It's the stopping reaction time. So if you imagine if you're going, so you get a signal and go. You get a, let's say, a typical reaction time for you. Let's say 500 milliseconds, make it a concrete example. If your go reaction time is 500 milliseconds. Now, I'm going to introduce a stop signal, okay, part way through. I might just do it on the board. So I'm going to tell you to go, okay, let's say with a nice arrow, and sometime later you respond, yeah, your reaction time. In fact, over many trials, you'll have a distribution of reaction time, some a bit shorter, some a bit later. But let's focus on that median reaction time to start with. What I'm going to do is, after the go signal, but before you've actually made a response, I'm going to give you another cue, like a beep or a red arrow changing colour, that's telling you to stop. Okay? And I can vary experimentally that interval. Okay? And what I'm looking for is the time at as I vary this interval, your performance will change. So if I give this, I'll say success, 100% success, if I give this stop signal really early on, you've barely got going, and you've got lots of time before you normally go, so you'll be near 100% success. But if I give it very late, if I give the stop signal just before you're about to hit that button, it's too late. So you'll be unsuccessful. And there's a nice sigmoid function in between, a sort of response function. And what we're looking for is that 50-50 point. Okay? So at 50% success, there's a delay, so I've just drawn this, there's a delay which gives you a 50% success. What I'm then interested in measuring is the time from that 50-50 time point to when is your normal reaction time. And this measure is the stop signal reaction time. Okay? It's not your actual reaction time, it's the stopping time. The point of that is, if this is short, it means you can successfully stop even if the countermand comes very late in the day. It means you're a really good stopper, you're good at inhibiting. If that reaction time is long, it means you need lots of notice to successfully stop. So long SSRT means you're impulsive, means you cannot stop easily. I mean, you can stop if you get lots of advance notice, but it's much more difficult for you.
The other point is that the go reaction time is independent of the stop reaction. They don't go together.
Yeah.
So it's still unclear to me, how did you test all these models to make sure which ones fit the best?
Yes. So you've got a set of parameters for the neurovascular coupling, half a dozen parameters about flow dynamics and where have I gone? How? So in your model, you have empirical priors which give a mean, expected mean, but also a variance on each of these parameters. They're empirically derived, they're not very controversial. They just explain the sort of the vascular reactivity. You also have some parameters on the intrinsic decay at each region. So if you stop driving a system, stop with all stimulation, a brain network would gently decay. So you've got time functions on the, it's actually modeled as an auto-inhibitory connection, it's a decay function. And you've got parameters of connectivity that you can either enforce as zero, in other words, you can take a connection out, you can force it to be at zero, or you can allow it to be a free parameter. Okay. So you're over a recurrent maximum likelihood estimator, the Laplace assumption, because it's a multivariate problem, you have a Laplacian assumption, makes it nice and tractable computationally, very efficient and fast. You then model what are the neuronal connections, what are the intrinsic connections of each region, and what are my neurovascular parameters, and you solve it all at once. Okay? What's nice about that is you allow each person, and under each drug, to have their own neurovascular response. So you're modeling the neuronal interactions, allowing for that individual neurovascular coupling during that scanning session, which varies a lot from person to person, and in principle, it might vary on and off drug.
So you fit this model for each individual?
For each individual, yes. Yeah, for each individual. And then you, depending how you want to look at group effects, we tend to use Bayesian model averaging as a various ways, or you can just take out the parameters. What I've done here is I've not done Bayesian. Let's have a look. Here I've done Bayesian model averaging, which is a precision-weighted averaging. In other words, because on those parameters, I get not just their modal value or expected value, I get an estimate of the precision or the certainty. So you can do precision weighting across my 20 patients, for example, and get this sort of model average, these figures here. Or you can extract the parameters individually and use them as dependent variables, as I've done here. Okay.
So would you do model comparison with one model, or you average between your own models?
You can do either.
But I'm asking, what did you do?
So what I'm doing here is for these 20 participants, these are young healthy subjects, I've done single subject modeling.
So for each one you pick the best model?
Yes, the best model, what I've done then is I've looked at what is the best model for the group, and I take that best group, on this experiment I've taken the best group-wise model, I've taken that model back to each subject and said, in that model for this subject, what are all the parameter values? Yeah.
So you do, in the end, look at one particular configuration of the network
In this experiment, there is a variation on this called random effects imaging, DCM, where you can take into account that within the experiment, different subjects' responses may be being driven by different models. So maybe some subjects operating under one generative network and other subjects under another. You can do that. Okay, but that's not what I've done here, but it's what I actually do later on.
And I have one more question. So the prior of the different models is just taken from prior, or do you have some knowledge?
So when you do your first experiment, we have a uniform prior over subjects. In other words, I have no reason to believe that subjects are different, and I have no reason to believe one model is preferable to another. So across those 20 models, I have a uniform prior. Now, it may be because when you do a replication experiment, you can make a case for saying, well, actually, when I look at my next 20 subjects, I don't go in with a uniform prior. The prior should actually be the posterior of my first experiment. Yeah? That's actually the proper way to do it. Okay? I tend not to do that because my experience is you're at risk then of everything becoming self-fulfilling. And what you get readers or reviewers, or even yourself, you come to your sort of third experiment, and what you find is you can only find what you knew before, which is actually Bayesian statistics for you if you're not careful. Although doing replication, you're properly taking into account your knowledge that you have after the first experiment. There's a risk to that, which is you won't be open to alternatives as much. Okay. Yeah. So it depends how you structure a series of studies. Okay. You'll see that when I take this model into patients, I could have taken the model set and the posterior distributions from my young subjects and used that as a set of priors across the models for my patients. But I chose not to do that. And that's deliberate because I thought, well, you could make a case that old people are different, so I should go back to having a set of flat priors for older subjects. Okay.
During your experiments, patients were on the regular treatment?
So we'll come to the patients in a moment. So yes, always. So I've always had patients on their normal optimum dopaminergic things. So I'm never suggesting that serotonin or noradrenaline will replace dopaminergic therapy, but they would be adjunctive or they'd augment dopaminergic therapy, particularly to improve cognition. And we know that dopamine is great for some aspects of the motor syndrome. It helps some aspects of cognition, but as we heard from Restraint, it actually makes other things worse. So the idea would be you can use promote dopamine as a kind of standard, 50 years of levodopa. I'm not going to change that. But it gets you so far, and it doesn't get you very far with cognitive deficits. So the idea is you add in atomoxetine or serotonin in selected subjects to help those cognitive impairments on top of. So all these studies on top of usual medication, and we took them at the normal same time of day. It's a crossover design, so each person came at their same time of day, and we of course looked at the motor examination, the UPDRS on each session. So where have we got to? Oh yeah, so patients, here we come. So we took this model set, we took the same experimental design, and we came to a clinical study. We came to those patients who were in the double-blind placebo-controlled crossover design, on their normal dopaminergic medication. So if you remember, when we compared the same 21 models, in the control subjects, we could look using both a fixed or random effects analysis, and you get the same model. The random effects analysis is really trying to take into account that different subjects may be acting differently, and that's important, I think, particularly as they get older, with heterogeneity increases, and especially with patients who are at different stages of disease. We've already seen how different stages of disease is quite critical for looking at your response to a drug. Maybe actually it may be critical for how you're undertaking a task altogether. So the leading model had, again, this interaction between the IFG and the SMA in their influence on the subthalamic nucleus. Now you'll see there's a subtle, so if you observe it, you'll see in the older controls, it looked like the SMA was modulating the IFG, whereas in young subjects it was the other way around. But actually those two models are so close and they have so much in common, and what they're really basically saying is there's a positive synergy between those two inputs. So how you would draw that, as Edson might, is sort of a minimally efficient wiring diagram, is one area modulating the connection of another or the other way around. I think it makes relatively little difference, at least for these purposes. They're both acting synergistically.
So sorry, if you simulate this, so is it possible to disentangle these two cases if you generate your own data from these two models?
We didn't do that here. In principle, you can. So other people who've done simulations of the nonlinear DCMs, you recover the right model. Depends how much noise you put in. Obviously, if you put in a lot of noise on top of the simulated data, you eventually get to the point you don't recover the generative model. But with realistic noise or signal-to-noise ratios, you do with DCM, you recover the network that was used to generate simulated data.
So you can also distinguish between this kind of SMA influencing the connection between the STM and AFG or the ground?
Well, the answer is you have distinguished between them in this model comparison because you've got to estimate the model evidence. Which the data, you can't argue with the data are real. The question is the interpretation on the generative models that might be generating those data. And here, this model was much more likely than the alternative.
Okay, so I guess my question is, if you're saying, if I understand correctly, that in some subjects it seems that there's SMA is influencing the connection between IFG and STM, and in other subjects it was the
What I'm saying is the experiment in young adults, you had this relationship was the other way around. Whereas in older adults, it's different now. I don't want to run away thinking there's an aging effect. These are different cohorts, okay? And these two models have, this synergy is really much more in common than any of the other models. So there are various reasons why one group of young people might come up with one flavour of that synergistic model, and another group of subjects who happen to be 50 years older have a different model, okay? Within group, yeah, so if we come back to here, if I can track it down, the model that was winning in, I have to go forward and back a moment, in C. Yeah, the model that wins in the older subjects is this model. Okay, they belong to a family, so there's a family structure. If we come back to the models, there's a family structure here. So at one level, you've got linear family versus non-linear models. So a family of models. In these, there's a family in which the IFG is modulating the SMAs, and these four belong to a family in which the pre-SMA are. So you can think of this as a hierarchical arrangement. These aren't just random generative models, they're hierarchically arranged systematically. Now, if I was doing this now, I'd probably do the model selection, base model selection, I'd do hierarchically. I'd ask in a sequence of questions, linear versus non-linear, and so on at the first level, and then narrow down. What used to happen is you put all models against all others, okay, with a flat prior on a single test. We tend now to do it hierarchically. Okay. I don't want to run out of time, so it'll be. Oh yes, okay. So, what happens in patients? The best model to fit the patient data when they're on placebo versus atomoxetine that is, but they're still taking their dopamine, okay, is a different model, okay. So I can just see this model it's a different model, okay. It's a model that retains this subcortical interaction, but what it loses is this connection between the IFG and the SMA, okay. So you've lost that influence of the SMA on the IFG as a cortical-cortical interaction. We put the patients on atomoxetine. At a group-wise level, the most likely model is then the same as controls. In other words, at least group-wise, you've normalized the model that can generate the data. Okay. There's a bit more subtle. If you take into account that some subjects will differ from each other, and you've got a random effects analysis, we actually see a bit of a mixed picture. We see that really these two models are in balance almost, really telling us that some subjects are operating under the model which is equivalent to being on placebo. In other words, some subjects, that atomoxetine is not really having an effect. And other subjects have reverted to the normal model. So some subjects, by atomoxetine treatment, you flipped it back to having the architecture of a normal stopping network. Okay, but not all. So heterogeneity in your group. If we take this coupling, so we say that the change in the IFG's input to STM, we take that parameter, okay, and we say, does that change on versus off atomoxetine? Yeah? Yes. How much it changes varies, okay, and that variation depends on your disease severity. Okay? In other words, people with severe disease, not in years, but in overall severity, have a positive effect of atomoxetine. So atomoxetine can exert a positive effect on the activity, as we saw in the earlier slides, and the restoration of connectivity, but only in those subjects who are sufficiently advanced in their illness. Okay? And if in fact you give it to the whole group, you lose that effect.
Yes, however, it's effect after one single dose.
All this is after a single dose. Yeah. So heterogeneity, really important. So atomoxetine, to the noradrenergic treatment, restores the pre-SMA's connectivity to IFG and increases IFG's connectivity to the subthalamic nucleus, depending on disease severity.
So when you say the positive effect,
Yes.
as I understood that you compare it with the positive effect and the drug program.
Yes.
So have you checked the treatment group before the drug application, after drug application, to compare it?
So essentially taking, so crossover design, looking at those subjects when they're on placebo versus atomoxetine, do you mean? Or looking at the placebo group versus controls?
Okay, this is
So these are controls, different set of people. These two graphs are the same patient group, either patients on placebo or patients on atomoxetine. So this is the change in connectivity between their placebo session and their atomoxetine session. In other words, does atomoxetine in the same subject, always within subject, increase that connectivity? So I've taken a very specific task, that stop signal task. Okay. And there's an advantage to that because you can link to the animal models. It's very easy to operationalize experimentally, but it's quite niche as a task. So the important question was, what about real life things? What about those behaviors that patients do that are so disruptive, you know, gambling or other forms of impulsivity? So with Angie Gahagia, we showed that the benefits of atomoxetine behaviorally, without imaging now, in a different set of subjects, a whole new set of Parkinson's subjects, also made people more conservative during gambling tasks. They sought more evidence before they would commit themselves to a decision, so an information sampling task, and they had an effect on motor inhibition on the stop task as well. Okay? So it does appear to generalize to many different aspects of inhibition. And what's actually quite nice is if you look in resting state fMRI, you can also see changes in coupling from that lateral infrafrontal gyrus to the medial frontal wall. You get a change in covariance even during rest in the same subjects. So it's,
Have you examined other drugs like amoxicillin?
so this is all with atomoxetine. Do you mean with the...
Atomoxicillin, some drugs, the like atomoxicillin. Have you ever examined in this model?
So we've not used reboxetine or duloxetine, we've not used methylphenidate, so there are ways, and we've not done an on-off dopamine trial, so there are ways you might want to try and explore the specificity. In about 20 minutes, you'll see why we haven't done that.
And this effect is dose dependent? Do you have any?
No. It's not, strictly speaking, it's not dose dependent. We gave everybody one dose, 40 milligrams, which is quite a generous therapeutic dose. It is dependent on the level in the blood. So if I give the plasma level, so if you're the brain, yes, this is dose dependent. How much drug is being delivered to you, in the plasma. If you think that's dose dependency, yes, it's dose dependent. Because when I think of a dose, it's how strong is a tablet that goes in the mouth. We've only used one dose. But it is dependent on the plasma level. Okay. So if you,
Have you checked how long this effect lasts?
Yes.
After
Well, we know that it lasts, we've done day curves where we do this behaviorally do this task every hour for 7 hours. Okay, so once you get up to peak, by 7 hours, you're still at 50% of peak and you get a modest effect in the subjects. So the effect it has within subject is very stable during a day curve. What we've not done, and nobody's done, is to look at chronic treatments. Okay? There were 2 randomized control trials of chronic, by that I mean 3 months, not years of treatment, but chronic, 2 to 3 months, atomoxetine treatment is well tolerated. Okay? But those 2 studies by Dan Weintraub didn't look at this type of cognitive measure. It was actually used for depression symptoms, and they didn't have cognitive measures, sadly.
So you predict that it was with chronic, it was with longer, the effects?
So I haven't got any data to make a sort of informed statement about does this work over extended periods of time, chronic treatments. No, that experiment needs to be done. That becomes a clinical trial. So these experiments are experimental medicines, mechanistic studies, albeit with a drug, albeit in patients. That is very different from doing a clinical trial. Okay, so as soon as you look for clinical effect of chronic treatment, there's a legal framework for clinical trials, and you'll see when I talk about how you do these studies, why I've shied away from that. The work is partly cost.
For me, it's about intriguing because you increase the level of dopamine or serotonin. But in condition of Parkinson's disease, you've got huge oxidative stress.
Yes.
And increase the level of serotonin and other neurotransmitters. Increase.
Less serotonin.
Okay.
Yes, less serotonin. A lot less. Yeah, 70% less, 50, 70%. Yeah.
And I have a question to the hemisphere because you showed the comparison between controls and Parkinson patients.
Yes.
It wasn't only the difference was in one hemisphere. Did you, when you know perhaps cognitive modeling, is the effect for both hemispheres?
It wasn't one hemisphere. What it was, we took the areas that seemed to be principally involved. So we took the left motor cortex on its way out for a right-handed button box. The medial frontal cortex, we took a midpoint because it's right on the midline, so we took a symmetric region of interest. For the infrafrontal gyrus, we took the right inferior frontal gyrus because that is where the greatest activations are. That's where we know from the Chamberlain studies 10 years ago that atomoxetine increases activation. And right lesions in the infrafrontal gyrus have a greater impact on behavior than the left. So we had right infrafrontal gyrus as a kind of the dominant control center, if I put it in that slightly sort of crude terms, but left motor cortex, and the midline structure we took as a midline. For the subthalamic nucleus, we used probabilistic maps from Beata Forsman, who's done some really elegant work to look in humans where in sort of XYZ coordinate space you can find the subthalamic nucleus. We used her atlases for that. Yes?
So there's one connection between the PSMA and motor cortex directly, so it didn't show the changes
that
there.
Change.
But what, in a different task, do you expect any changes there, or is it not changed so much like the disease?
It does change. You either need to use, if you switch to different methods, so we've looked actually under serotonergic modulation in the coherence between pre-SMA and motor cortex, and that does change. That changes with serotonin, it changes with some subcortical strokes. If you lesion subcortical white matter, you get an indirect effect on the pre-SMA to M1. There's a lot of imaging studies in Parkinson's disease showing a change in pre-SMA. We then looked at, there's a paper in 2001, where we looked at the effect of an attentional distractor task, so doing a motor task with or without attention on the connectivity of pre-SMA to motor cortex, and it is abnormal in Parkinson's disease. We then did that on and off dopamine. What we tend to see is patients, at least when you go into an acute task, we're not looking at the overtrained monkeys who've been in the box for years. As you go into a novel situation, patients are quite keyed up. They're new to the task. They're trained, but it's still quite new. They're really at ceiling. So we saw less of a drug modulation of that connectivity, probably because they were in a highly stimulated and stressed state in the scan on a new task. So disease and drug does affect the pre-SMA to motor connectivity, but you have to think quite carefully about the context in which you're studying those patients. If you email me, I'll give you offline some references for those.
So, in regard to distribution of receptors, do you have any idea about the other regions which are affected by the systematic injection of atomoxetine?
So that with atomoxetine.
In your model.
So do we model, what was it, the other neuromodulators? No, we don't. The reason is, well, we don't have PET imaging to look in these same subjects at, in principle you could use norepinephrine transporter, PET ligands to look at noradrenaline. We'd love to do that. You could, in principle, do altansoin PET to look at the 5-HT2A receptor binding, for example, across the brain. We didn't do that. I don't think it would fundamentally change our conclusions or interest in these two drugs. It would be a sort of refinement, perhaps. It's an enormous undertaking to get old, frail patients on and off drugs repeatedly back into the scanner. It's a huge undertaking, and it's expensive and takes a lot of time. So it just became impractical to add on PET scanning. So MR scanning is about £500 per session. We're doing 4 sessions, so it's £2,000. To do a norepinephrine transporter PET is £3,000 per session per participant. It's not in our hands, it was just a step too far. But these are some of the limitations you come up to. I think it was your heartfelt question, why do you do exercise? It's because life is too short. But these are the right questions to ask. Okay, so when we come in the right session, you'll see what's involved, and we'll see if you think, oh, James, you're making a lot of fuss, you're just moaning, get on with it, do some proper experiments. Here we are. So I want to come on to can we predict who responds? I made a lot about the fact that some subjects it works and some it doesn't. And I've given one crude measure of disease severity to say, well, it seems to work better in people with more advanced disease and less earlier. In principle, there could be some feature of our patients, or multiple features, feature 1 and feature 2, which somehow in combination identify those that respond and those that don't. Okay? So I've shown that linear example initially, or one feature disease severity that seems to separate responders, advanced disease, and non-responders. But it may not be as elegant as that. It may not be linear. There could be some sort of set which in combination define responders, even though neither feature on its own separates responders from non-responders. Yeah? So to do that, we're going to need to use a method of machine learning or supervised machine learning called support vector machines, where you'd feed in a whole series of features of your patients. There might be clinical features, age, sex, levodopa drug dose, atomoxetine plasma level. There might be imaging features. There might be the degree to which you activated the frontal cortex, or that diffusion-weighted imaging measure of the structural connectivity of cortex to basal ganglia. So you've got lots of features, some clinical, some easy to get, some experimental-based. So we said, if we had a predictive model, what might a clinician or trialist who meets a patient who knows clinical information and their baseline structure, because most patients have a structural scan, and this sort of information, the mean diffusivity, so the right and left frontostriatal connections, disease severity, levodopa equivalent dose, cognitive status, age, and sex. These are things you might have when you're making a decision. Should I give my drug or shouldn't I? Should I recruit them into a clinical trial, thinking they might respond, or could I know enough about them to know that they're not going to respond, in which case I wouldn't even put them in my clinical trial. Okay? That sort of predictive model. We also had a post-predictive or post-hoc mechanistic model, which includes all of these features, but also some of the information about what effect the drug had. You can ask retrospectively, when the drug worked, was it because it increased activation, for example, okay? Or was it because it increased the functional connectivity? So there's various parameters with support vectors. You feed in the features, it does a feature selection, and it weights the features, and you do that on a training set. You say you take your first 19 subjects, okay? Train up, see if you can get a good model, and then you test that model on the subject you've left out, okay? Of course, so you're on an independent sample. And you go back to your data, you leave a different subject out, you train on a new set. Take the optimal model as best as you can in those 19 subjects, and test it in the second subject you left out. So you can do a cross-validation, leave one out within sample, but leave one out cross-validation. And using very simple measures, it turned out to be very reliable to predict which patients got better and which didn't. And I don't just mean a 1-second reduction in your stop signal reaction time. I don't think that's trivial. What is the sort of effect that most drugs cause? Well, how big an effect does dopamine have on your UPDRS, disease severity measure? It's not a cure, it drops your UPDRS by about 30%. If you take a good antidepressant, by how much does it drop your Beck depression inventory? It's about 30%. Yep.
Slightly stupid question, but does covariation across the different measures make a difference in terms of how you model it?
No, that's the joy of using a support vector machine. It just incorporates all the information. Yeah. So yeah, it's actually why you might use this method.
What's the measure, what's the response that you need?
So we then took, for this experiment, we said a reduction in your stop signal reaction time. To what extent does it move your impulsivity measure back towards an age-adjusted norm? Okay. Does it improve you? And we said, we're not going to get you perfect. We're not going to make you like a healthy control. But if we can narrow the gap by 30%, similar to what good antidepressants do, or similar to how much of an improvement in motor function does levodopa cause. Yeah, so we took 30%. And with that was some very simple information. So for the effect of atomoxetine, all you really needed to know to get this good classification accuracy was that structural connectivity between the frontal cortex and the basal ganglia on the DTI, and how much levodopa they were taking. So here, finally, we start to see an interaction. Okay, so I made much about that specificity between the serotonin reuptake inhibitor effect of citalopram and the noradrenergic uptake inhibitor effect of atomoxetine. But what we're seeing here is the effect of whether the drug works does depend, to some extent, on how much levodopa you're taking. And interestingly, this whole week, one of the running comments is we haven't really talked about the interactions very much between these neurotransmitter systems. We're seeing why this might be important.
Sorry, I'm a bit confused. So you have to go slide back.
Yes.
So in this case, so the predictive and constructive models, there are two separate things that you're looking at?
So we run two separate things. So two separate sets of models. In one model, we feed into the support vector machine this information, so the clinical baseline information. We allow the model to throw things out that are not contributory, but we don't even give it the fMRI and the functional imaging data. In the other set of models, we do give it the fMRI data.
Okay, so in the post-predictive model, you also do SVM investigation?
Yes. Yeah.
Okay, and so then how do you look at which of the elements is important?
Because in the modeling support vector machine, it looks as a feature selection process, and it throws out features that are not contributory. Yes, effectively, it looks at whether that feature contributes to accuracy. And if it doesn't, by a certain threshold, you can adjust that threshold, it removes it. So what you're looking for is a simple model, in other words. Ideally, you can...
How do you know that you are getting a norepinephrine dopamine interaction via levodopa and atomoxetine? And this is for two reasons.
Yes.
One is we know that levodopa doesn't impact the normal noradrenergic system.
Yes.
But does it restore norepinephrine in a depleted noradrenergic system? And second, atomoxetine increases dopamine levels in the frontal cortex by blocking dopamine uptake into the noradrenergic.
It might do. Theoretically, it can. If you actually do the dialysis experiments, Bymaster's papers, so I hope you're not the senior author, I know the first author, Bymaster, did dialysis and showed that atomoxetine doesn't change dopamine. So theoretically, it could by acting on dopamine transporter. But in the dialysis studies, it didn't touch it at all. So, at least in healthy animals. Okay. So, I think we need to bear in mind the potential for that dopaminergic mediation of atomoxetine's effects. I personally think that is probably a small contribution, but not non-zero. One of the hints that it might be important is this interaction. Of course, the amount of levodopa you take is proportional to disease severity, so it's not entirely clean. But I'm just highlighting that here's a suggestion that we might need, as you say, to take more account of this interaction.
Now studies are now doing stop signaling animals. There's no effect.
And humans. So if you...
Because the D122 affects cancer, because they do have an effect.
If you look at methylphenidate, so there's a nice study with methylphenidate, it's a dopaminergic, that does improve stop time, but levodopa doesn't. So that would suggest to me that the methylphenidate effect is a noradrenergic effect. It's a sort of slight subtraction logic, but the human data would suggest that it is.
It brings us back to an important point, James, which is, how does atomoxetine work and what do we know from animal studies?
Yes.
Now, we know that atomoxetine improves stop-signaling reactions, and we know that it does so in the orbitofrontal cortex, which may be a homologue of this inferior frontal area. But Darren, you've done studies of atomoxetine in animals on the locus cerebrus. So can you just briefly say, summarize those results? I think it affects basic stimulation.
Yeah, basically, Andrea Barry found that atomoxetine increases basic responsivity and sort of signal the noise of basic tectonic activity in LC neurons when they're given sensory events. These were in animals, so it was limited that way, but it suggested that you might have elevated basic release of norepinephrine in response to sensory events.
Yes.
So it's perhaps not just tonically increasing norepinephrine, but there might even be an enhancement of phase.
Yes. And I think that becomes more important when we look at the effect on attentional shifts, which I'll come to in a few slides' time. I think it's really important to bear that in mind. And with a long-acting drug like atomoxetine and with a temporarily crude imaging method like fMRI, you can't resolve that. You'd need to look to other methods. Okay. So what was the added value of imaging? Well, I think in the experimental medicines context, it's more sensitive than behavioural effects. That's one thing to say. So it can demonstrate that target engagement. So we have a strong prediction about the homologs, as Trevor said, of those animal regions. So we can say, in as much as it's working, is it in the system, the region, and its network that we would predict? And imaging is really powerful to show that engagement. It provides some simple tools for doing prediction and stratification. And with that, it really provides this platform for experimental medicine studies. For me, actually, the other real value is it provides a really important link between the animal work and the human work. Okay, and I think that's underestimated, the need to actually reinforce this translational pathway. So, next 10 minutes or so, I'm going to come on to other cognitive effects of Parkinson's disease. I sort of took you through this sort of taxonomy of cognitive deficits. I want to come to set shifting, rule shifting now, okay? And I'm going to look at the intra and extra-dimensional shifts together and contrast those with reversal. And in Trevor's talk on Monday, he introduced the CANTAB implementation or formalization of extra and intra-dimensional set shifting, here with showing stimuli with shapes versus lines. And this is a sort of formalism of a long-standing clinical test, the Wisconsin card sorting test, when patients would have to sort a card based on its color, its number, or its shape. Okay, so using different features or dimensions of the stimuli. With the IDED task or series of tasks, really, you can look at simple discrimination learning and reversal, compound discrimination reversal, and then up to intradimensional and extra-dimensional shifts. So you want to know if the effects you see are specific to extra or intradimensional shifts in the context of people who can learn. They can learn a simple and compound discrimination. And that's really important to know that you're not just seeing a non-specific learning deficits. So if we look at patients with Parkinson's disease through simple discrimination reversal, compound discrimination, intradimensional shifts and its reversal, and an extra-dimensional shift, there's many CANTAB studies. Actually, I couldn't find the plot from the original paper, which is somewhere. Anyway, you could choose many different papers. They all show the same result, which is basically extra-dimensional shifts are a bit more difficult, but they're for healthy controls. They're very much more difficult for patients with Parkinson's disease. Yeah. When patients with Parkinson's disease are pretty good at the early stages, they can learn simple discriminations. They're also a bit impaired at the reversal stage. You get a hint here and a hint here that their reversal is not normal. Okay. So the other nice thing about this study is it compared medicated and unmedicated, which means dopamine. And dopaminergic medication had very little impact on the extra-dimensional shift. Yeah. Another example why that is important cognitive aspect of Parkinson's disease is not being helped by standard dopaminergic therapy. Now, I'm not saying dopamine has no effect. So if you go to marmosets and you do 6-hydroxydopamine lesions in the frontal cortex, you do get a bit of a deficit. This is complicated by perhaps reciprocal changes between the cortex and the basal ganglia, and some noradrenergic effects that came with this. There were modest noradrenergic effects from the 6-hydroxydopamine lesions. So, yeah, I'm not saying there's no effect of dopamine, but as we'll see, I think the weight of evidence is this being a non-dopaminergic system.
Can I just explain? Yes. This is absolutely correct. So when we did duty dopamine in the monkey frontal cortex, actually, if anything, ED shifting was improved. That's what you see there. Paradoxically. But the reason for this is because the animals didn't form sets. They didn't have stable representations. So they could learn exemplars, but not general concepts. So dopamine is involved in learning representations, but not in shifting them.
Right.
So then you could become stronger. So indeed, dopamine depletion doesn't really impair at all.
Yes. And if you come to, so I think these are back to rats, if you lesion the dorsal noradrenergic bundle, the principal outflow from the locus ceruleus up to the cerebrum, what you get is a clear difference in extra-dimensional shifting, which really isn't there at these other stages of the task. You appear to have some selectivity on ED shifting. Interestingly, if you deplete serotonin, so deplete serotonin, you get no effect on extradimensional shift. Okay? So we have a noradrenergic effect in extradimensional shifting, not much of a dopaminergic effect, perhaps even some facilitation for the wrong reasons, but certainly not a benefit, and no effect of serotonin depletion. Okay. If we just further evidence that that noradrenaline is important. This is I've forgotten. This is Jill McCoy's work. That again with lesioning noradrenaline, you get an increase in the Translational criteria. In other words, worse performance on extradimensional shifting, not intradimensional shifting. Okay. That effect is reversed by atomoxetine. So a lesion in the noradrenergic system, okay, can be compensated for by atomoxetine, okay, even at quite small doses. There's no dose dependency effect here. The atomoxetine had no effect, and nor did the lesions, on intradimensional shifting. So neither lesioning noradrenergic system nor overtreating with atomoxetine made a difference. There's a nice little twist here, which is that in sham animals, atomoxetine actually made things a bit worse. It's another state dependency. You take an animal that's deplete of noradrenaline and you treat it with atomoxetine to restore, you improve function. You take an animal that's doing perfectly well, thank you very much, and you give atomoxetine to overdose, an unnecessary increase in noradrenergic system, and you're going to make things a bit worse. Okay? More state dependency, reinforcing this perhaps ideas of U-shaped functions, that there's an optimum, and either too little or too much will impair performance. Just picking up on that serotonergic story, serotonin, I said, didn't have an impact on extradimensional shifting, but here back in animal models, it has a severe effect on reversal learning. Okay, so serotonin linked to reversal learning, picking up on themes that Roshan set out in more detail yesterday. So where do we go from here? One more thing here. Oh, yes, sorry, that's the sustained effects. And the reversal learning, again, not dopaminergic dependent, but serotonergic dependent. So reversal, serotonergic, not noradrenergic, not dopaminergic, okay, at a crude level. Maybe some subtle interactions we're yet to tie down. So here we've got some predictions in the context of Parkinson's disease. Extradimensional shifting and reversal, they're both impaired. Extradimensional shifting related to that noradrenergic deficit, rather than dopamine, rather than serotonin, could be restored by atomoxetine. And reciprocally for reversal learning, it is impaired. It's serotonergic, not noradrenergic, not dopaminergic. That might be restored by citalopram. So we wanted to look at this with our patients with fMRIs, a kind of readout for efficacy, looking at activations in that neural system for reversal and set shifting. We had to use a different task. The classic IDD task is not well suited to an fMRI. You can't do repeat exposures that you need for the study. So we adopted a task that Adam Hampshire and Adrian Owen developed, where you see compound stimuli, one of these at any one time, and you might say point to this face, and the next trial you point to that face, and I told you got it wrong. Well, clearly this face is not, you can't track in that face, doesn't give you the right answer. So he makes a shift, to the other face, and then carries on choosing this other face, no matter which side it appears, gets it wrong again. He now switches out of faces, because tracking either face hasn't led to positive feedback, so he switches now to a house, sticks to that house, follows it through, gets it correct. So he now has some positive feedback. Oh, when I was following any of the faces, I got no feedback. When I pick on this house, I get some feedback. I'll take that forward, I'll test that again. You've got a hypothesis. So again, he or she picks on the same house, it's because it alternates side, picks on the same house, follows it through, gets more feedback, and at 3 positive feedbacks, in other words, 6 trials in a row, we say that's criterion. It's a 50-50 choice, that's significant. So we can tell from the sequential behavioural responses when someone has made an extradimensional shift. Okay? We can also tell when they made an intradimensional shift in their sequential behavioural responses. We can look at when they meet criterion, we can change the sets, or change the stimulus sets, and again, look over time at different forms of intra versus extradimensional or non-reversal shift when it's a whole new set of stimuli. When Adam and Adrian ran this in fMRI in young, healthy subjects, there was a very clear anatomical dissociation, much as you'd have predicted from the animal literature, that these lateral prefrontal area in green, seem to be particularly active on successful extra-dimensional shifts. Okay? And both polar, orbital, and to some extent more dorsal frontal regions of the parietal cortex were active at the time of reversal. Okay? I think when I came to the study, I was really focusing on this orbital and polar frontal activation, really based on some of the marmoset lesion studies of Trevor and Angela Roberts and the forebrain depletion. There's been much less work on that parietal cortex. So we were fully expecting this frontal activation to be the critical one. As we'll see, we weren't quite right. But there is at least a clear anatomical distinction, which will help us in identifying that pharmacological distinction. So you've got pharmacological and anatomical hypotheses here, which we undertook in this double-blind, placebo-controlled crossover pharmacological fMRI study in patients, okay, atomoxetine, citalopram, or placebo. Behavioural, you can think of behaviour in two ways. You need to be a bit careful in your statistics. So you can compare controls with patients on placebo. And really, there were more errors. Patients found this more difficult. That's not a great surprise than age-matched controls. And so this is patient placebo versus control. Separately, the controls just provide normative data. They weren't on drugs. So to look at the drug effects, we have to look at a within-patient effect. So looking at placebo, citalopram, or atomoxetine. And it's rather difficult to see clear behavioural changes. There's some buried in there, but of course these are going to be compounded by disease severity effects. There isn't a glaring, group-wise, nice, simple drug effect on behaviour that everybody gets better on atomoxetine or everybody gets better on citalopram. But we'll see there are effects to be had. What we're going to then look at the imaging. Hang on, what have we got this? There seems to be a slide missing. Let me come to, there's a slide missing. Nope, it's missing. What I was going to say is we took regions of interest, and I had a slide to show you where we looked anatomically from the functional imaging. We basically took those regions that were there in the young, healthy subject study at Adam, Hampshire. So I was just going to show you that. And the activations that we get in controls and patients lie in those same areas. There's a nice slide because it just shows a replication of the basic effects of task. Okay? So we can then look at the drug effects in those regions. And for some reason, I want to show those data, so let me give me a moment. I'll see if I can find out why it's not coming up. So it's going to take a few moments to warm up. What I might just do is to come back to the second session just to sort of change the pace a little bit and get you to think about how you would run such a study. So if you had a wonder drug that you felt could improve symptoms in a disease, let's say Parkinson's disease, and you want to test it in humans, okay. So I've got wonder drug, I think it's going to work, how am I going to do it? Does someone want to tell me put into words what a hypothesis would be that you're going to test? Any volunteers wants to try and articulate a hypothesis about whether the drug works?
Well, ultimately, it's going to work on the functional outcome, isn't it?
Yes.
In the real world.
Yep.
So how do you get to the real world from your experiment, from your trial?
So we're going to actually say we want a drug that works in real-world settings. We're going to come back a bit and say we're going to look at experimental neuropsychological paradigms or an experimental medicines approach using sort of a laboratory-type task, okay, which we think may be relevant to real world, but we'll come back to a task. So a sort of starting hypothesis would be drug X improves patients on the task. Yeah? Would everybody be happy with that as a testable hypothesis? Yeah? Put into words. Blank faces.
So the task predicts functional outcome in the real world.
Contingent on that, yes. Can anybody refine that hypothesis that drug X improves performance on the, yep?
Because you were saying earlier that it depends on the severity of the disease as well.
So can you put it into words?
Like drug X, but as a function of the severity of the disease, everything you just said doesn't.
Yeah. So drug X improves function in these patients on the task, contingent on or dependent on a disease variable, let's say disease severity. Yeah?
Could you say that with a percentage improvement above baseline?
Yes, so as you type precise, what do you mean by a recovery? What do you mean by an improvement? Do you want to set a threshold for a meaningful improvement? Yeah, important factor. Because you're not interested in if it's like a 1% improvement. Well, maybe that's just chance, or maybe it's irrelevant. You know, if I change your reaction time by half a millisecond, no matter how many noughts on your p-value, I don't care, yeah, clinically. So, but if I say, well, I can actually, you know, make you behave normally and completely resolve a patient-based deficit, then that's more meaningful, yeah. So you want some threshold meaningful. Any other ways you might refine the hypothesis? I've used the word improve function. What does that mean?
In a general way, I guess you want to improve disease outcomes using like a score or something. So you want drug X to, within some time, increase UPDR or decrease UPDRS scores.
Yes, okay. So I'm going to say that's an ultimate goal, but those are terrible rating scales. So UPDRS doesn't relate to cognition at all. Okay? So yeah, hang on. So those sort of rating scales maybe don't exist. There isn't a good rating scale that captures the sort of breadth and complexity of cognitive function in Parkinson's. You could do an MMSE, for example, useless, right? Absolutely useless. Because the test doesn't contain the elements that map onto or reflect those cognitive difficulties that people had. Yeah. So if you go to my taxonomy of cognitive deficits in Parkinson's disease, none of those are really reflected in MMSE. Yeah. And I'm going to say, well, and also you've got bad outcome scales. I'd say that's a large-scale clinical study. Let's come back to the laboratory. What would an effect in a laboratory experiment in patients mean?
Quality of life.
Sorry?
Quality of life.
Quality of life. That's a really important long-term goal. So we look at that in a clinical trial. So a clinical trial that might want to have quality of outcome measures is going to cost $500 million. You'll only do that if a small clinical trial costing $10 or $20 million looks promising, and you'll only invest 10 or 20 if you think your chances are goer. So there's a bottleneck, a sort of pinch point in translational medicine, which is you've got all this really exciting stuff coming out of rats and non-human primates, drugs that seem to work and be effective. None of them ever reach clinical outcome, never reach meaningful outcome like quality of life. Okay? And there's a really important bottleneck as you bring it into humans in what I might call experimental medicines. Okay? So not clinical trials looking for these important clinical or quality of life outcome measures, but just saying, can I improve the system I'm interested in? For example, can I improve activity? Okay? Can I improve the connectivity of the brain during the task? Can I improve, by function, the performance of a task which is a bit unrealistic as a laboratory measure like inhibition, okay, response inhibition, but at least it's tractable and quantifiable, okay? And it gives you a quantifiable basis to look for the ability of a drug to improve the system you're studying, okay? If it works, then you can go to the next step, scale it up, look at perhaps cognitive outcome measures. If that works, you'd really scale it up and look for quality of life measures, okay? So you're going to come back to you, I've got a wonder drug, it's great for Parkinson's disease, okay? And you say, well, how are you going to test it? Oh, it's going to make Parkinson's disease better. Well, what aspect? Yeah. Motor versus cognitive, okay? Quality of life, a cognitive measure, or some sign that the neural system that underlies that cognitive measure, that contributes to quality of life, that neural system is being restored or augmented. So that's the stage where I think a lot of these experimental medicines, imaging pharmacology studies are working. Okay? It means you can link back to the animal work, but it gives a go-ahead signal that this drug might work and how to get it to work. So I've said that if I was talking to a drug company who makes this one drug, I want you to spend 20 million on a phase 2 trial, which is only that. Do you know how many people in a phase 2 trial? Roughly how many in a phase 2 clinical trial? For 20 million, how many patients would you get through for your 20 million?
200?
Yeah, somewhere between 50 and 100 maybe. Yeah, tiny. Not enough to get you a license, not enough to get you a license to publish, to sell. To get a phase 3 trial, of which you need 2, to get a license to sell your product, to recoup all the money you've invested, how many people in a phase 3 trial typically? Yeah, about 1,000. Yeah, but that's hard. Yeah, and that's going to cost you for each of those, you need 2, and they're each going to cost 500 million. Yeah. So to even get to that point, you want these earlier stage studies. And I think there's a real value of this sort of experiment. And even if for most of you working with animals, talk to those working with patients or clinical context to try and push things through that bottleneck to get them out into larger scale sort of global impact. It looks like we might be working. So this is the effect of atomoxetine on the extra-dimensional shift. you don't see, so between these three areas that in normal people are active on this shift, in the anti-atriocingulate and the prefrontal cortex. Now, if you just look at this graph at a group-wise level, you don't see a lot of effects. Okay? You're trying to read a pattern. Does atomoxetine cause more activity or less, or a bit of both? It's unclear. And the reason it's unclear is within this group-wise effect, there's a lot of variability. So you need to break that variability down and say, what is the activation during extradimensional shifting in relation, coming back to our old favourite, of disease severity, the UPDRS. And really, there isn't much effect of placebo, that's not significant, but there is an effect of atomoxetine dependent on how severe your disease is. Okay? So whether you see an effect of drug depends on disease severity. So it becomes really important that you set up that in your hypotheses. You don't just want to get to the end of experiments, oh God, it hasn't worked. Let me correlate everything with everything else and hope something comes up, yeah? That's not good science. You need to build in from the start an expectation that you'll have effects of disease severity. Okay. Interesting, that effect of disease severity was seen at all three regions. Okay, so this whole network has the severity-dependent activity effect of atomoxetine. So each of these subjects is also represented the placebo. So I haven't actually plotted that difference effect, but it is there. So you have atomoxetine does affect that EDS network in some, but not all patients. Let's look at reversal learning. Again, if you look at the group-wise data, it's a rather complicated pattern. You know, this is the grey bars is placebo, and black is treatment. Looking at the citalopram effect, and it's not there. It's not really apparent in the group-wise data. But again, you've got severity effects. That the effect of citalopram versus placebo is there, but in relation to disease severity. Now, I was wrong in my hypothesis. I was expecting that effect to be seen in the orbitofrontal cortex, to be honest. Okay. I can't get it right all the time. It was there in the posterior parietal cortex, but at least that's an area which is normally active for doing reversal learning. Well, that's not the area that anyone seems to focus on. Okay. So, cognitive deficits or cognitive sequelae of that serotonin and noradrenaline can be predicted from the animal models, and there are restorative effects of atomoxetine and citalopram that are largely those that are predicted from those animal models and have retained that selectivity. So here we are. That's cool. I want to do it, yeah? So who wants to do a sort of double-blind, placebo-controlled pharmacoimaging crossover study in patients? Okay. What do you need? You need to get the money. That's the easy bit. You need to state your hypotheses. Believe me, that's the easy bit. You need to think, how am I going to test it? What do I need? And what about the administrative steps? I don't want to spend too long on this because I've got a little bit of frontotemporal dementia I want to show you in a moment. So we've talked about trying to be as precise as possible in your hypothesis. Don't just think you can rescue all this after the experiment and hope you can correlate things left, right, and centre. How am I going to test them? Am I interested in behaviour? Yes, ultimately. But I want insights, perhaps through the functional structural imaging into the underlying system. I might use another imaging method like MEG. I might use something else in humans, I might TMS or other things. If you're going to use MRI, you need to think about the sequence you're going to use. How are you going to use the MRI scanner? So if you've never used an MRI scan, you might just think you're going to put the person in outcomes and pictures, yeah? But it's not as straightforward as that. The way you use that scanner can give you more sensitivity to good things, like sensitivity to activation, but it can bring with it artifacts, okay, and changes in signal to noise. So being in a scanner is noisy, yeah? It's about 90 decibels, and you put earplugs in and hearing phones on the outside to try and protect hearing, but it's noisy and unpleasant. You can reduce about 25 decibels off that by tweaking the sequence, okay? You can tweak the sequence, it becomes quiet. And we thought when we first ran this study, that's great. We've got frail folk, they're coming in on 3 or 4 occasions, yeah? And if you're in a noisy room, you know what it's like someone's digging up the road outside your office, or they're trying to dismantle the building next to you. That noise all the time, it's hard. So we thought, great, you're coming in repeatedly. If we make it quiet, they'll want to come back, they'll be less distracted. It's brilliant. So we use this alternate sequence, okay? 25 decibels off, very pleasant experience for patients. What we hadn't quite tweaked is the alternate sequence, which is quiet and is brilliant for cortical imaging, introduces much greater susceptibility to iron and calcium deposition. Well, who gets iron and calcium deposition? Older people and people with Parkinson's disease. So actually we lost signal in much of the basal ganglia and the subthalamic nucleus. It's got no signal from subthalamic nucleus at all. Okay? We discovered this after the experiment. Yeah, I'll just a bit of hang my sort of dirty washing in public, because we hadn't got all the information correct. We had to rerun the whole experiment, okay, which was a headache. You might think about the environment. So you cannot imagine a worse environment for doing cognitive paradigms than lying on your back in the dark in a really noisy 90 decibel banging away environment. fMRI. I mean, who would design such a thing for cognitive experiments? Yeah, especially when you're not even measuring the neural signal directly. Yeah, it couldn't be worse, except it kind of works and it's totally safe. But you might want to switch within a moment to MEG, kind of a bit like EEG, but slightly better. Okay? You're sitting up, the lights are on, it's totally quiet. It's a brilliant environment, especially for cognitively frail and distractible individuals. And you need to think about who are my subjects at what stage of disease to make sure you've got enough dynamic range to see the effects of your interventions. There's no point picking a task that's great in young people, you apply it to older patients and they're at floor, or vice versa. You've lost that dynamic range. You need to really think about that. Am I going to study patients? Yeah, and patients is sort of what it's all about, ultimately, but they come with problems. Patients have lots of comorbidity. They move, they wriggle, they've got performance deficits. So if you've got a poor performance, how do you know that the imaging difference is due to having the disease, not just because they didn't do well on the task? You've got an ambiguity in your inferences. Okay? It's really difficult. Do you look at people who are healthy but related and might have some endophenotype, some biological trace of susceptibility that's enough to interrogate the system you're interested in, but without all these confounds? Okay? And exclusion criteria. So to get people into the studies I've talked about, there's about a 10-to-1 ratio, having to screen patients to getting somebody in the scanner on drug. About a third of the people can't take atomoxetine because they're taking a monoamine oxidase inhibitor for their treatment. About a third can't take citalopram either because they're on an antidepressant or they've had seizures. About a third can't go in the MRI because they've got stents or pacemakers and other stuff. So it's actually 30%. That leaves you 10% who are able to come into your study, and God, you hope they're willing to. You're super nice to them. So, and that's difficult, and even that's for people at the right stage. So you need to work with a really friendly research clinic who can access hundreds of patients for you to screen to get 20 or 30 into the scanner. And you need 20 or 30 people to even begin to pick apart heterogeneity.
So really, James, I mean, agreeing with you, you have to reject the thing you said early on, that the best model for Parkinson's is Parkinson's disease, right? Because really, as we all know now, when we start PET scanning them, we split them up into, massively different subgroups, which of course is completely relevant. I mean, you try to catch all these things more indirectly, but in a way, the better and cleaner, stratification of patients would be to PET scan them and run with concepts that have been put in place before you start the study.
Yeah, I don't agree with that. I would still say the best model of Parkinson's diseases is studying people with Parkinson's diseases. If you're going to see a heterogeneity, you need to study them all. Okay, I still don't think you don't get much insight into any of these patients if you study things that people that don't have them. We may get a little bit of better.
But you have your hypothesis, which drug will work in interaction with what degree and what combination of losses.
But it does it so differently in states of depletion from normal controls. Yeah. And there may be interactions. So it's complicated. In case you say, why don't you do 100 patients? Like we can do 100 rats, do 100 patients. This is why. When you say, why not explore other drugs? Yeah, I'd love to, but this is why. It gets worse. Let's see who you need. So to make one of these studies work, there's you. You need a really good clinical collaborator and a source of patient. Are they any good? So in my hands and Roger Barker's hands, if we see someone with mid-stage Parkinson's disease and we compare with a brain bank pathology, we're 90-95% accurate. There's a few mimics that throw you off. Yeah? If you take someone off the street who's seen their GP or even a general neurologist, right, they're probably 60% accurate. In other words, if you see someone who's got a diagnosis just out there walking around with Parkinson's disease, about 60% of those will have Parkinson's disease and the rest of other stuff. Right? So if you're studying Parkinson's disease, you do want to study Parkinson's disease, you don't want to study all the other stuff that's misdiagnosed. Okay? So you've got to have a good collaborator, and you need lots of patients to help you screen. You need postdoctoral scientists. Well, at the moment, that's mostly you guys, but as you move on and up into faculty positions, the powerhouse of your studies are good postdocs. Good postdocs are good at doing what postdocs are doing, and you're an unruly mob. You like to do what you do. It's quite hard sometimes to persuade to do all the other graft and grind that goes in. So I reckon in science about 10% is the fun stuff and 90% is dross. So if it's your data you're going to spend 2 years analysing, I think you should really care about the drudgery of getting that data. Yeah, of course, could I hand it to a research assistant? Yeah. Who's going to phone around and speak and make all the appointments and phone the taxis? Yeah. Well, research assistants, secretary can do that. But do you trust them? This is your data for 2 years. This is the make and break paper of your career. Well, I think if it was me, as I did then, I'm in charge of that. And from the very first phone call to a patient, even arranging the taxi, you're engaging the patient, you're bringing them on side, you're building trust, you're building loyalty to you. Because when you want to really put them through the mill, on and off drugs, in and out scanners, multiple visits, right? That bond that you've created through you caring that their taxi turned up on time, not joking, that sort of thing really matters. It means you get good data versus either no data, or even worse, bad data, right? Bad data is worse than no data. What about doing the neuropsychology? All of you could do good neuropsychology, but you might say, well, can't someone else do that? Research doesn't just run through the forms, yeah? Well, you want really good quality data. And, it's foundational for the study to work. The only problem is you can't be getting good quality data doing the neuropsychology test on your patient if actually what you're thinking about is the scanner free? Has the scanner crashed? Have my bloods been spinning for long enough so I can pipette off the supernatant? So you actually might need to partition the work, okay? But really, don't, as some postdocs, you just say, well, that's the RA's work, isn't it? No, this is your ownership of the study, and it really pays. But oh God, this is drudgery. Yeah, this is really hard work. And you're going to need a doctor. You're giving old, frail people drugs. Yeah? You need someone around. When they keel over, faint, throw up. Yeah? They do it not very often. They'll have a fit. It's very rare, but it sometimes happens. You need someone on side that's going to turn up and help you. Yeah? Unless you're a clinician, you can do it yourself. You need a good pharmacist who's going to help you get proper blinding of your drugs, overcoating, that's manufactured drugs, putting them in a gel capsule. Who's going to help you not only work out your randomization schedule, but make sure that randomization errors don't happen. Yeah, because it's so easy. The patient turns up, you're busy doing something else, as a nurse on the clinical research facility, takes a pot out, gives them to your subject. Yeah, and if they give the wrong drug, it's not their study, but it's yours. Yeah, and the pharmacist, you want someone who's going to make sure you don't get randomization errors on the day. And who's going to keep your drugs at the right temperature and in the dark and not get lost and have them all traceable. Yeah. So pharmacists. You're going to need people to help run the scanner, and you may, depending on your skill set, you may want statisticians or image analysts. Where are you going to do the study? Well, you're not going to do it in your office. You're going to need a clinical research facility that can cope with patients. Yeah. And that's got an infrastructure and nursing staff and forms to do. They're great for patients because they're comfortable, they're clean, you've got cups of tea and snacks, and you can leave the patient in the hands of somebody else while you go off and check the scanner. But it's a level of complexity. You're going to need to take drug levels. Drug levels matter. You have one dose, but almost a 5 or 10-fold difference in the drug levels between people, and you want to know that. So you're going to take blood. Well, you can't if you're doing the neuropsychology. Yeah? Who's going to spin it and pipette it and store it? Well, of course you could. It's not a very difficult thing. But you can't at the same time as doing everything else. Okay? You need someone, a good colleague, can analyze it. And the chances are, if you're in an imaging facility, you're not in a biochemistry lab, so you need to work with people to do drug levels. Ralph Regenthal in Leipzig has been fantastic for our studies, but there's others around. If you're doing PET, you need really good radiochemistry. PET is not plug and play. You can't just kind of order over the internet and inject it. It's really it's bespoke on the day for every patient. You need good radiochemistry. And that's the easy bit. Yep. So, last couple of minutes on this sort of rant about actually doing these studies. Who do you need to get permission from to do a study like this? Hands up. Who do you need permission from? You want to do a study tomorrow. Who do you have to ask? Sorry? Medical council, yeah. So you need to be qualified and registered medical research council. Anyone else? Yeah, so now a research ethics committee or an IRB, depending which country you're in. Sorry? Yeah, there's some sort of equivalent to the Home Office. You're in animals, you've got Home Office licenses, yeah? So you sort of think, what's the equivalent of that madness of Home Office licenses, yeah? I believe we have our equivalent for human studies, yeah. So
data protection agency of some
yes, the information governance officer of your institution, data protection, who's going to store your data?
And the patients?
Yeah, you're going to ultimately their consent, yes. That's not even on my list, actually. Any other people? Well, for me, as grant funders, research ethics committee, head of department, someone above you needs to know it's okay to go ahead, yeah? The research and development office, stuff that's happening in the hospital on research, they need to know what's going on in their name. So there's a sponsor, a research operation office. The sponsor in the UK system is someone who's got a legal responsibility for ensuring that study is properly conducted. In other words, if there's a mistake, who gets sued? Usually it's the university hospital, and there'll be differences across countries, but ultimately someone in your institution will sign off that we, the institution, take responsibility for this study. It's called a sponsor in the UK. If you're doing a clinical trial, there's clinical trials unit. Okay? If you're not, you still have a clinical research facility. Where's that patient going to pitch up and hang around while the drug's working, being absorbed and do the studies? You need to make sure you're insured, at least in the UK system, okay? Insurance office. Recruitment might have clinical research networks, these are the UK terms, but some sort of recruitment network for getting hold of patients. If you're using a device, you might need your clinical engineering colleagues to check it it's safe to apply to patients. Health and safety. Under EU law, that's instantiated this thing called the Medicinal Products for Human Use Regulatory Authority, which basically says, is it okay to give that drug to a person? Okay. And they sign off your protocol. They basically say, is it a clinical trial or not? Your pharmacist helps supply, storage, randomization. If your facility is off-site, so I may want to scan at a scanning institute that's not my own department. Yeah? So you've got to get permission from them to take your study to their grounds. You're taking blood or tissue, you need human tissue. If your study involves transferring samples to another site, so we send our blood to Leipzig. Well, that's a material transfer internationally. Well, our lawyers get involved if I let them know it's happening, get terribly excited. And they want all legal frameworks for under what auspices are samples or data being transferred. Even just sharing a scan, okay, or changing the jurisdiction, there's a legal framework there. You need to make your staff have got good clinical training, that they're properly employed and trained. You're doing gene therapy, there's some special bodies in the UK and so on. There's a lot of people, right? It makes, the Home Office licenses are grim. I don't know what it's like in the rest of Europe, but animal work is complicated. But there were some special issues here. So there we are. It's fun. You need to think about the heterogeneity and all that. Another aspect. So once you've got started, you've got all your permissions. Who am I going to study? People vary by genetics. We saw the difference between goal trackers and sign trackers, and how important that was in performance. And it seemed to kind of be largely a trait. People may vary by gene function, they vary by the pathology, how long they've had the disease, how bad they've got it, other illnesses, obvious things. So you need to work out, in my experiment, do I want to get a kind of homogeneous pure group, equivalent to my nice inbred colony or strain of rats or colony of rats, where everything, from the day they're born, I know how many bits of chow they've eaten, a homogeneous group. Because if you do, you can do a nice clean group comparison, patient, non-patient. In practice, that's impossible. Okay. So you can take the alternative view. So I'm going to take as maximally varied patients, early, severe, mild, moderate, demented, non-demented. Because if you've got lots of variability, you can use that variability to understand the causes of heterogeneity in your patient population. Yeah? So the more variants, you can understand covariances and relationship between your different types of data, your imaging, your drug response, and your patient characteristics. But the more variability, it becomes easier. Actually, the very worst thing you can have, in my experience, is trying to get a homogeneous group and failing. So you've got people that are a bit varied, and they're varied enough to mess up a nice, clean result, but they're not varied enough that you can pull apart the sources of variability. So you end up with the very worst situation, okay? And I think I've certainly made that mistake over the years, and I think many people have. So there we are, heterogeneity. You can use it as your friend in the neuroscience, okay, and really embrace heterogeneity. I think traditionally people have tried to shy away from it. So because of time, I'm going to skip over a little bit. So look the other way. Oh, I say it's worth it. Yeah, it's worth it. Because you can take a clinical problem, a nice observation. You can show how drugs in principle can work, at least in a laboratory setting. You can generalize. You can try and understand in terms of structure and function. And you can build predictive models to try and take forward in clinical trials. It's great fun for all those hazards. And you work with great people of all sorts. There we are. So it is worth it. Now, because of time, I'm going to look away for the next few slides, because I was going to have a bit of a rant about U-shaped functions, but there may not be time. I'm going to take a deep breath, because we're going to change gear. I've talked about Parkinson's disease for the last hour and a half. In the last 20 minutes or so, I'm going to try and switch to, 20 minutes? 15, yeah. Just frontotemporal dementia. I'm going to show you a case. Just, hopefully this will work. So you can see it's disinhibited, inappropriate in a session. Yeah.
You don't like them? No. Why not? You meet people in here. You don't like meeting people? No. Why not? I don't know. Did you used to like meeting people? Yes. I didn't want to see how I was with reserves when I was younger? Yes. I was a reserve person? Reserves, yeah. And being a reserve, you tell porkies, I used to tell porkies. Yeah. A lot of lies. Yes. Yeah. I don't know, tell the truth all the time now. Even ask people, I don't know what it is, but I tell the truth all the time now, even ask people. What, can you give an example when you told someone the truth and it hurt them? Yeah. That's not a fact. She's a fact. She is. It hurts them. Don't let it down now. Any change in what you do like to eat? It's sweet stuff. I like cakes and now. Can you resist them? If there's cakes in the cupboard, can you leave them there?
So, disinhibited, jocular, labile. There's things that were true. His wife was fat, but you just don't say it, do you? You know, you rein it in. You don't say it. It leads to these non-empathic behaviours, but really it's a control, an inhibition failure, because what he was saying is true, and he says lots of true things that are unpleasant, or not upsetting. He's not malicious. So he's got frontotemporal dementia, personalities are grossly changed, a lot of these disinhibited behaviours. If we look at what's happening, normally we'd wait for the sort of background brain, but we wait for the brain to come to the post-mortem. At post-mortem, if you take a slice, for example, through the midbrain, you might see the thalamus here, putamen and globus pallidus. Under the microscope, you can focus in on this little area here, perhaps the subthalamic nucleus. Even from the back of the room, can you see the other tissues, it's quite a sort of smooth pink, and here it's a bit speckled and white, odd little dots, can you see that? It's got little vacuoles. Those are where cells have gone. If you zoom in on that and you stain for tau, you've got some healthy cells, healthy nerve cells here. You've got cells that are chock full of hyperphosphorylated, misfolded tau aggregates, and you've got some little ghosts where there used to be cells. Okay, so healthy and unhealthy cells and little ghosts. So this is a very aggressive pathology of frontotemporal dementia. There's some other things about it. It's not just that it occurs in the frontal and temporal lobes, as the name suggests. It's actually quite layer-specific. So if we look at this is from the chap you just saw in the video, actually from his lateral prefrontal cortex. We look at the cortex, you've got the peel surface, the white matter's here. You've got layers 1, 2, 3, 4, 5, 6. Look at that. You can see just a lot of cells in layers 2, 3. So the very neuronal substrate on which your selective drugs going to be operating have in themselves selective loss. So those superficial pyramidal cells bear the brunt of this illness early on. Okay. So when you come to think about those models of cortical function and those neuronal circuit models, they are selectively targeted and not just pharmacologically. Frontotemporal dementia reduces or severely deranges serotonin function. So here this is from some 2 old studies, but basically showing that 5-HT1A and 2A receptors are markedly reduced in frontal and temporal cortex. There's another paper. The red line here is the normative data. So in frontal and temporal cortex, they're markedly reduced, not in parietal cortex. So you've got severe dysregulation of serotonin. Interestingly, that's exacerbated by genetic heterogeneity. If one looks at polymorphisms of the serotonin transporter, so looking at the variations in the long polymorphic region, you can see that the volumes, also perfusion, this is perfusion imaging, the perfusion of the frontal lobe is also affected. So you've got disease and genetic trait influences. You can look post-mortem at, for example, the binding of radiolabeled citalopram in a close-related illness, PSP. Again, it's markedly reduced in the frontal polar insula. Just building this story that these patients have a severe serotonergic deficit. Not all neurotransmitters are down. Just because you've got atrophy and degeneration, not everything's affected. I've learned to be more skeptical as to cholinesterase, but if you use here a PET ligand in living patients to try and get an estimate through the kinetic modelling estimate of the amount of cholinesterase, you can see in controls and patients with frontotemporal dementia, it's pretty normal, both in the cortex and thalamus. Not the case in other diseases, But at least in FTD, you've got a severe serotonergic deficit, but normal cholinergic function. I'm just going to play another brief video just to give some flavour of... So this lady sits here tapping and clapping much of the day, okay? Drives everyone up the wall, okay?
What does it say on his jacket? What does it say here?
Happy birthday.
Whose birthday is it?
So repetitive, stereotyped behaviours. You've got this fatuous grin and smiling.
No, but is it your birthday?
She will do this for hours.
Whose birthday
Okay.
is it?
Happy birthday.
I've not asked her to do this, it's just, yeah. So, next chap spends his day filling in books, like this, okay? Page, after page, after page of it. Sometimes words, sometimes non-words, sometimes numbers, you know. It's not a subtle illness, yeah. And these stereotyped, repetitive and disinhibited behaviours are high risk for patients, and they're absolutely devastating for carers. They're exhausting, unsafe, and it's very, very stressful to live with. I was going to sort of try and spend a bit of time talking about how uncertain diagnoses are, but I think I'm just going to skip over this. So look the other way while I whiz through the next few slides. I want to pick up a little bit later on. So if you take patients with these illnesses and variations of illnesses, the way in which you measure effects, okay, the way in which you might want to measure impulsivity or motivational deficit and apathy will affect whether you can or can't see a drug effect. Okay? So you know, what am I going to measure? So if we took 200 cases we saw in this region of England, and we really, through the book, different scales, you know, questionnaires that are commonly used in human work for impulsivity and apathy and motivation. Some it's in the titles about impulsivity scale or apathy evaluation scale, pleasure and motivation inventories and depression inventories. You can measure all these. We can look at various scales of the severity of general cognition or disease severity. And we can also then use a series of more laboratory tasks of impulse control, inhibition, gambling, sensitivity to expected rewards, and so on. So we can measure all these. Of course, if you measure all these tests in many people, you've got 20 test measures here, each of which has multiple outcome measures. You have a very large problem. There's too many variables. Okay. So from this little set, there's about 85 to 90 measures. Well, you can't just compare all those patient groups. So we want to do something more principled, particularly if they all tap into a small set of underlying problems. So we use a sort of hierarchical PCA. We take something not projecting, there we are, put them all through principal components analysis. So trying to extract those modes that represent the sort of commonalities of different ways of abnormal behaviour. So if you've got two tests that tap into the same thing, they'd converge on one mode. If the tests are tapping into very different biological systems, they remain separate in their variance across the population. So we can look at the table's a bit complicated, but essentially you take all these different tests and break them down, they cluster together. Some variability in the population speaks to how patients rate themselves, some speak to how carers rate them in apathy or impulsivity, and actually quite separate to this is performance on the neuropsychological tests. So what this tells us, this component, these are orthogonal components, that the variability on information sampling, cued reinforcement, no-go or saccadic control, the variability on these tests across the population doesn't correlate with the carer ratings as to how bad the diseases are, and it doesn't correlate with the patient's own assessment of how bad they are. So neither is right or wrong, they're different. And skipping ahead, we can look at when you come to symptomatic treatments, to see the effect of a neuromodulator, a drug treatment, I'll show you a study in the next few slides, but to see the effect of that neuromodulator on impulsivity or motivation or apathy, you need to find tests or questionnaires that map onto the right system. So if you have a wonder drug that treats pharmacologically behaviors that relate to this neuroanatomical system and its pharmacology, you won't see that working if all your tests are based on another neural system. And it sounds like a sort of obvious point, but there's a lot of studies, clinical studies, that use drugs that might work on one system, but they're measuring it on the wrong system. Okay? and you get a null result. So let's take this forward. Serotonin, I've said, is impaired in frontotemporal dementia. If we look at the areas that are active on the task, this is in the Parkinson's patients, so we get activations in this infrafrontal gyrus and temporal lobe. This is similar to the areas of atrophy in our patients, and those are the areas that also have chemical depletion. Now, I can't undo atrophy. I'm not going to have a drug that's going to really restore the bulk of the brain in some massive sort of neurogenesis. I can't undo atrophy. But you could aspire to correct that pharmacological deficit, okay, so with a neuromodulator. So the question, the hypothesis is, can you restore response inhibition, the inhibitory deficit, by enhancing serotonin? We switched to MEG, and I'll skip over the details of that. It's essentially it's a brain mapping method, which when we validate it, it's very good for patients because the lights are on, it's quiet. You essentially get activation maps, and we validated it with human in vivo cortical intracortical electrocorticography in humans. So what do the results show? Well, if we look at a no-go task, okay, which as I said before, we'd expect to be serotonergic dependent, okay, as it was in the Parkinson's patients. We're using MEG, not MRI, but essentially at a simplistic level getting an activation map. Here in that inferior frontal gyrus, if you compare controls to the patients on placebo are worse. They have a lower activation, okay, a lower response on this task. Okay. You treat them with serotonin, acute single-dose serotonin, and you restore it. So it says talipram to restore serotonin, and in this region you increase the activation. So you successfully reverse the deficit in that focal region. Okay. Sorry? It's just single treatment, yes, a single dose, yeah. So we might over lunch talk about why in some contexts like mood disorders you need chronic treatments, but you don't in terms of impulsivity. Okay, they're very different. You can look at more. The nice thing about MEG is you've got a much sort of richer repertoire of measures, and you're scanning the brain at 1,000 hertz. So you can actually look at oscillatory dynamics, these oscillations that we heard about yesterday, looking at theta to gamma coupling, ripples, these high frequency events that are very important for particular cognitive operations. So what I've mapped out here is over time on each trial from 0 to 1.5 seconds, the power of at different frequencies. And in normal people, on a no-go trial, you get a marked beta desynchronization, enabling a sort of behavioural state change from your normal go response to withholding behaviour. So it's very characteristic. Desynchronization, so blue, is a loss of beta power, which has a resynchronization rebound, okay, half a second later. Patients with frontal dementia just don't have that. So they've lost that physiological signal, the oscillatory dynamics, or oscillations that are relevant. Does that matter to complex behaviors? The answer is yes. When we measured their relative beta power in the patients, it correlated with a questionnaire that relatives had of how severe are they. Do they take clothes off in public? Do they take food off other people's plates? Do they say things embarrassing in public? Very kind of ecological, everyday behaviours. And the more severe you are behaviourally, the less you manifest this beta desynchronization. So it's a physiological signature, but that is very relevant to everyday difficult behaviours. So if we then go from the sensor space, an imaging machine, we can project into brain space and look at where that signal is coming from, coming back to that inferior frontal gyrus and the pre-SMA. There's two regions, prefrontal regions, so important for cognitive control. Both of those have beta synchronization. It's absent in the patients and restored with citalopram. So you're now looking not just at the activation, but that restoration of a much more complex physiological signal that supports successful inhibition. So enhanced serotonin restores functional markers of that inhibition system. Okay? Didn't change behavior because the physiological imaging is more sensitive and more relevant, I think, in an experimental medicine setting. So I'm going to skip over, one slide. Look at noradrenaline. This is from one of the patients. This is from the brain of the chap we saw in the video. You can see the dark staining here from your melanin in the controls, locus coeruleus, and even this is cut taking a slice through the midbrain. You barely see it. You get catastrophic loss of the locus coeruleus in these patients with PSP. And it's early. When we've looked at people who've got PSP pathology but hadn't yet manifested symptoms, but we can see the pathology, the first place it comes is locus coeruleus, really, really early. So I'm going to skip over some of the modelling because it's haven't got time, and summarise. So where do we start? We've shown how fMRI and other imaging modalities can focus on neural systems for inhibitory control. You can demonstrate, you can restore function in proportion to disease severity, so heterogeneity is important, state-trait interactions. We can get to more sophisticated modelling, trying to map those neuronal interactions using generative models, that method called DCM, and relating those parameters to structural connectivity. We can use physiological methods to show the absence or the restoration of physiological signatures in patients on drug. And had there been time, I'd have talked a bit more about some more sort of formal computational models of behaviours. But they all point to this multiplicity of drivers. Okay? And it's not all about dopamine. Coming back to my first slide, if you want to understand the disorder and restore function in a disorder such as Parkinson's disease, that's your focus. And I'll end there. Thank you. Sorry to have run over.